start.
Dear colleagues, thank you for the invitation. The IGEA Heart Valve Group, who pioneers in Greece the field, and we proceed to the case of a TAVI failed small bioprosthetic non-fracturable valve menacing the left main. I have no conflict. It's about a 76-year-old lady, rather small, who has typical symptoms of severe aortic stenosis, of bioprosthetic aortic valve in her case. She had been operated back in 2017 with a single bypass with a lima to the LAD and SAVRF with a trifecta 19 millimeters due to severe aortic stenosis. So we are 8 years later. She also has hypertension and dyslipidemia. She has a sinus rhythm with a small QRS duration of 80 milliseconds, no other abnormalities. Her ejection fraction is impaired slightly, 45%, with mild left ventricular hypertrophy, inferior wall hypokinesis, and an aortic valve area estimated at 0.6 square centimeters. And otherwise, moderate MR, moderate TR, and systolic pressure of the pulmonary artery at 45 millimeters of mercury. The coronary angiogram I will show you in a while. Her Euroscore 2 was 7.84% calculation. So this is a coronary angiogram. This is the left system. There is an occlusion of the LAD, chronic occlusion, just after a second large septal branch, which is mostly appreciated to the right. There is ostial occlusion of the circumflex and a large diagonal, which is somehow atheromatous but without severe disease. There is a patent lima which feeds the LAD and retrogradely the occluded circumflex, and the right coronary artery which has no significant lesion. We did the CT in order before proceeding to the TAVI, and we saw that the trifecta inner diameter was calculated, measured here at 16. I think it's a little bit underestimated. The Valsalva sinuses were comfortable, but the left main was rather low, and the anatomy at just above the annulus was narrow. The axis, the iliofemoral axis, had no particular problem. And here we saw that the VTC, down on the left, that the VTC to the left main was 1.8 millimeters. That is quite ominous, and the height to the STJ was 9.9 millimeters. So this is the premeditation for implanting an Evolut 23 in this failed bioprosthetic valve. The trifecta, I remind you, is non-fracturable, but at least we did not have the problem of the right coronary artery, where the VTC was calculated at 6. We know the measures that we have to take for this case. Since we have a VTC less than 4 and less than 2 in our case, we had to protect the left main and probably had to treat with snorkel stenting. So we knew that from the beginning. We know that trifecta is not fracturable, but there is a case that somebody mentioned in the Hellenic Journal of Cardiology, a fracture success with the true balloon at 24 at 16 atmospheres, just one case. The more realistic expectation regarding the trifecta is to post-dilate in order to remodel the posts of the trifecta and have a better effective orifice area for the new valve that we will put inside. And we have to take in mind that the VTC that we calculate with the software of Thremensio is virtual, and sometimes the risk is overestimated or underestimated regarding what will happen in reality, depending on when, how and if we post-dilate the valve. So our plan was to do the procedure. We were 3 operators, Dr. Triantafyllou, Dr. Papas, and Dr. Dedelias. We had the procedure planning, conscious sedation, main axis right femoral artery, preclosure with 2 perclose, secondary axis the left femoral artery, that we used to have a guiding catheter to the left main. We put a stent weighting in the left main, a drug-eluting stent of 3.5 by 30 millimeters, and we did the valve crossing. We had selected the Landerquist as the wire in the LV to have better support, and we were ready to do snorkel stenting and what is necessary to treat. So this is the initial part of our implantation. We see to the right mainly that the left main, if we release the valve without protecting the left main, probably that we would have closure. So this is a left system that is partially protected since we have a lima, but nevertheless we did not want to lose it. So before releasing the valve, we implant the stent, then we release the valve, and we do a post-dilatation with an Atlas Gold balloon at 18 millimeters at 16 atmosphere. We used the simplified dual interflator approach for bioprosthetic valve fracture, which can be done by one operator as is described here. And then we post-dilated the balloon of the stent once more at 18 atmospheres. We had a good angiographic result. We had also an excellent hemodynamic result with no interventional gradient. That was verified by echo, that our colleagues mentioned that the valve, the Vmax was around 1.5 to 1.7 meters per second. So we were quite happy with the result. The iliofemoral axes were okay as well. And some comments. This is a case that happens about in 1 to 200 TAVIs that we have to do something to prevent coronary occlusion. Snorkel stenting has shown good midterm results, but we also have concerns about long-term outcome in these cases. The alternative is the leaflet splitting techniques, basilica, and other techniques such as unicorn or the shortcut device, but they are more complex and more cumbersome and more costly. And furthermore, there are reports that they are not more efficacious and safe, such as this report from 2014, which shows that the MACE, even if we do basilica, are not better than if we do snorkel stenting. So that was our approach to the case, and for the economy of time, I will stop here. Thank you very much.
Thank you very much.
Congratulations, Dr. Triantafyllou. You showed us very clear that pre-planning evaluation and CT analysis can be very helpful, and you can manage successfully such cases. A comment from Dr. Papas.
Costa, I have a question.
Also a question.
Sorry, Father. I have a question. In the case of valve with a dysfunctional, like here, dysfunctional defector, which are your calls about that? You know that if you will use this procedure.
It's a very difficult valve, which is out of the market at the moment because of a failure history. We have to take care of the implantation height of the new valve. We have to select, it's better to select a supraannular self-expanding valve, such as the one that we used, in order to have a better hemodynamic result. We have to think about creating some space by post-dilating mostly in order to remodel the trifecta and accommodate and create more space for the function of the new valve. And since these cases very, very, very often have small anatomies, we have to take care of the coronaries.
A comment?
I would like to thank Dr. Sparigas for his kind invitation, and I would like to congratulate Kostas for his great talk, which highlighted the ways to overcome the main limitations of valve-in-valve TAVI, which are PPM and coronary artery obstruction. He chose the proper valve system, a self-expanding valve with supraannular position of the leaflets. He performed aggressive post-dilation in order to remodel the surgical valve, and he protected the left coronary artery by performing chimney stenting. I have a short question, Kostas, about the antithrombotic therapy in these patients. What is your strategy? Do you see any role for oral anticoagulation?
The actual patient did not have an indication for oral anticoagulation. We know from popular TAVI that the trend in TAVI is to treat with single antiplatelet therapy. For this kind of cases, I prefer to, for this case, we had to do dual antiplatelet therapy anyway because of the stent. And for the duration, I think I would keep it at least 6 months and maybe more for this case.
Also a short comment from Dr. Zacharopoulos.
Kostas, as always, great job. There are two spots I would like to touch up. You already said that, but I would like to stress that. And that is one, that the chimney technique is very safe, and it's a very easy or a very easier approach to tackling problems like how to protect your coronaries in such cases. The other one is that I think that as time progresses, we're going to be seeing more and more cases with situations similar to that, regarding that you're going to have longer, thicker leaflets interfering with your coronary ostia, especially in the cases when you're doing TAVI in TAVI or other valves, surgical valves that have been produced implanted. So I think that leaflet management and leaflet modification before the procedures is going to be something that we will be discussing more and more in the next few years. And having that said, though, I think it was a perfectly planned case, and congratulations on that.
Can I say something about leaflet modification? It's true that leaflet modification is not done in Greece, I think, for the time being. But we have to start thinking about it because the future is as you described it. But it's not a panacea because even you have to have correct alignment in order to be efficacious. Otherwise, you will have to do cathedral. You will have to remove the leaflet if you have a leaflet of the TAVI valve in front of the coronary ostia. So it's not a panacea, and even for de novo TAVI, if or a valve-in-valve with bioprosthetic valves, if it's not 100% guarantee that you will not have obstruction, I think 7% you have obstruction, and you have to do chimney anyway.
Costa, another question is, in the case of a chimney or snorkeling and stenting, we have the opportunity, or it is possible for re-intervention in coronaries? It's a very, I think, tough question.
For cases with self-expanding valves with high frame, I think it's very, very difficult to imagine how will you manage to do it. I think there is a case of re-intervention after chimney, but in a case with a slow frame, with a low frame, and I think it's Adam Taleb that had described it. It's with the title "Going Down the Chimney." I have seen it, so it's possible, but under specific circumstances that make it technically possible.
Okay.
Okay, thank you, Dr. Triantafyllou, and we move to Dr. Georgopoulos.